Sweet Talk is a weekly 20-minute podcast brought to you by the Continuing Education Workforce Training Division of Idaho State University's College of Technology. This podcast is part of our continuing outreach efforts, and the format is conversation. We're having conversations with businesses, professionals, entrepreneurs, community agencies, and in all cases, difference makers. You can find us on Apple Podcasts, Spotify, and SoundCloud. So subscribe today. Take 20 minutes and hear from people living in your community who are making a difference in your community. It's time to get started with Sweet Talk. Hello, everyone. This is Jason Batalden, the Assistant Director here at Continuing Education Workforce Training. Paul, good to see you today. The sun shining.
Good to see you today.
Is the sun shining in your neighborhood?
It is. It's going to be 49 today. It's beautiful. It's spring-like. I heard birds chirping this morning. No, I'm not there with you yet, Paul. Just okay.
So spring-like isn't until I don't see, until all the snow is gone.
Okay.
Then it's spring-like. So,
right. Well, it's spring-like in Pocatello. Sorry, you live in Idaho Falls.
Man, sometimes it's a different planet up here. I'll be honest. Hey, we've got an exciting show today. We've got Raylyn on our show today.
Hello, Raylyn.
Hello.
and Raylyn, the guest today is connected with your event that you got coming up here. So please let everyone know kind of what you've got going on.
Yes, we have Emergency Medicine Conference coming up April 30th and May 1st. This is an event that is coordinated between ISU, Continuing Education Workforce Training, and Portneuf Medical Center. We are so excited that they've come in again as our title sponsor and have allowed us to be able to really hold this conference. We are able to hold the cost down because of this title sponsorship to a mere $20 per person, which is really a bargain for all that you're going to be able to get at the conference. We are bringing in our keynote speaker is Eric Bauer. He's the CEO of Flightbridge, and we're excited to have him as well as many, many wonderful presenters from our hospitals around our region, even a presenter coming from New York as well that's going to come and join us. So it's going to be a great conference, one that if you have anything to do with emergency medicine, you don't want to miss this conference.
Right.
Excellent.
Yeah.
And we're glad to be bringing it back too. So that we're excited. Last year's conference got put on hold just like just about everything else on the planet. But so we're excited for sure for this conference to come back to Pocatello this year. So that's great.
Yes. Looking forward to it.
Yes. You have a special guest on today. Do you want to introduce them for us?
Yes, I would love to. We have Dr. Kevin Ohalloran here. He is a traumatologist, actually an orthopedic traumatologist with Portneuf. And I'd like him to just kind of take over and give his formal introduction.
All right, sure. So thank you very much. Appreciate being here with you guys and being asked to be here on the podcast. So my name is Kevin Ohalloran, and I am an orthopedic traumatologist. And what that means is a specialist in bone surgery that also has subspecialty training in trauma. So that would be the very high energy injuries that unfortunately we see in folks with things like gunshot wounds, motor vehicle crashes, falls from a height. And so that is what my subspecialty consists of. And I don't know if you want me to go into sort of origin or where I came from or any of that, or
you bet.
Sure. I'm 44. I was born and raised in Minneapolis, Minnesota by a single mom. My dad died when I was 2. And so my mom put up with me for a number of years before remarrying with my stepdad, and he helped put up with me and they raised me. And then my mom and stepdad had a couple of kids, my younger brother and sister. And so that forms my family. They're all in Minnesota. Unfortunately, my stepfather has passed away. At 18, I joined the Army as an enlisted man, and I spent 4 years on active duty. I was stationed in El Paso, Texas at Fort Bliss, and Fort Hood, Texas, and Camp Casey, South Korea. And after getting off active duty, I decided I wanted to go to college. And I'd always been a decent student in high school and wanted to do something a bit with a social aspect in terms of helping people, but also with a science aspect, and that was medicine. So I found myself in the course of medicine, and I initially wanted to be a family practitioner. And when I was in medical school, I went to University of Minnesota for undergraduate, and then I went to Georgetown Medical School in DC. And in my first year of medical school in DC, I found that I strongly disliked family medicine. So I was a bit confused as to where I was going to go. And I had been a mechanic in the Army, and I happened to do an away rotation in Nicaragua at a small hospital in a town outside of Managua, the capital. And when I was there, I saw an orthopedic surgeon putting a tibial nail into a gunshot victim's leg. And I thought that, first of all, I was making sure that was actually a doctor, because I had no idea what orthopedics was, or especially orthopedic trauma, and fell in love with that career field and pursued it from there on out. And I ended up going to the Bronx in New York for my residency, and my fellowship was in Baltimore at the Shock Trauma Center. Along the way, I met and married my wife, and we have a 13-month-old, and we are happily settled here in Pocatello. We moved in July. We moved from Florida, where I'd worked for the previous 4 years at a level 2 trauma center there. I was the junior partner there. And here I'm the senior partner and the junior partner, because I'm the only one. So I'm kind of both. We just bought a house and just moved into a house. And so we're enjoying that. And we were talking before the show a bit about the idea of getting one or more dogs. So that's kind of where we're at. And we're building a trauma program in terms of orthopedic trauma at Portneuf to mirror the already existing trauma program in terms of general surgery trauma that already existed. And it's been very successful so far. Very busy, but very successful.
That's awesome. So PMC, or Portneuf, they have a well-known trauma center. And so bringing you in as an orthopedic traumatologist, what has that meant for that program?
Sure. So it's a great question. The orthopedists, for the folks who've heard of orthopedists, these are specialists in bone surgery and the treatment of disorders of the musculoskeletal system. All orthopedic surgeons go to medical school, like all doctors, and then they go to residency where they become orthopedic surgeons. And then in the United States, about 90+% of orthopedic surgeons subspecialize, and that's what's called a fellowship. So after your residency, you then proceed on to a fellowship, and those fellowships can vary from pediatric orthopedic surgery to spine orthopedic surgery to joint replacement to sports medicine, and that gamut includes also trauma. So starting somewhere in about the 1960s, orthopedic surgeons began to have a singular focus on trauma. This started in Switzerland and has advanced throughout the world, of this idea that we can do better with fractures. And eventually that developed to the point where we now have a subspecialty field in orthopedics devoted just to fractures and high energy type trauma. So that was what really drew me and what I pursued. And adding that to the orthopedic surgery community here in Pocatello basically fit that one piece of the puzzle that we were missing. We have great joint replacement surgeons. We have great spine surgeons. We have great, just everyone, sports medicine folks, all these folks that take care of people and have been taking care of people here for years. The one thing we were lacking in the trauma center was having orthopedic trauma subspecialty. And I think that's what, we've been able to now keep patients here in town that have high energy injuries that otherwise would have ended up being transferred either up to Idaho Falls or usually down to Salt Lake City to the university. So that's been really the piece that sort of fit in the puzzle. And to some extent, unfortunately, we've been busy, because I say unfortunately, because usually when I meet people, it's on a bad day for them. And so but we have been able to keep a lot of folks here that otherwise would have had to have traveled very long distances for their care. And sometimes that can even be dangerous, traveling substantial distances to get care when you're in extremis or severely injured.
Mm-hmm. So I'm going to kind of back up for just a question, because I want to talk the word trauma in the medical sense. So my background kind of comes from the psychological side, and that trauma refers to an event from my perspective, right? Some sort of traumatic event. But when you use that term in this context, especially in medical and treatment, does that term carry a different meaning like an event? Is it extent of injuries kind of definition, or that kind of thing?
It's a good question. There are a number of different definitions of how we would describe trauma. There are certain criteria, for instance, for listing someone as a trauma patient when they come to the ER for reasons for insurance and all of the things that doctors tend to hate, because I personally dislike insurance. I just kind of like to think about the medical aspect, but there are all sorts of underlying definitions. The way I like to think of it is a unforeseen negative event that results in some sort of tissue injury, and in my particular field, and almost always a fracture, sometimes a dislocation, which is where a joint moves. So I guess I have a more general or less sort of medicalese type definition of it, and that can really run the spectrum. There are folks who just slip on the ice and twist an ankle playing basketball. And you fracture your ankle. That's a trauma, all the way up to a semi crossing the midline and hitting a car, and so it's sort of, there is a wide spectrum, and that really the delineation of how trauma is manifested and how it's treated would probably be more the gamut of the general trauma surgeons, kind of Drew McRoberts and his team, because they're the ones who really are in charge of stabilizing these patients when they come. Although traumatologist is in the name of my specialty, it really is, I'm not the guy who's putting in chest tubes and resuscitating patients. I am the guy who comes in and takes care of high energy fractures that typically are outside the realm of the average orthopedist. Sure. So it's, it sounds fancy in our name to say traumatologist, but in the sense that I'm not the guy who's there at the bedside when they first come in until I'm called, I guess would be a way to put it.
So you're kind of the guy that puts people back together again. Not to use the childhood rhyme, but yeah.
I'm the puzzle guy. Yes.
Yeah, right. Okay. Very cool.
But at first, it's sort of, and it is important. I think that highlights, your question highlights a very important aspect of medicine. And this is something that it's a team. I kind of highlighted that I was the one piece of the puzzle, but it is a puzzle, right? There's a whole, sometimes I think about in the operating room, we even talk about when we're discussing whatever we talk about in the OR, just the sheer number of people it takes to take care of one traumatic injury. So someone gets in a car crash and has, say, a femur fracture, and you think about the number of people involved in that, from the police and the paramedics that respond, to the people in the ER, to the janitors that clean up the trauma bay after they're done, to going to the floor, going to the ICU, the nursing teams that take care of the patients, then the operating room, all of the people that are involved in the operating room, everything from cleaning it and preparing the equipment to cleaning up after we're done, to taking x-rays in the OR. It's just, there's a massive spectrum of humans involved in taking care of patients. And so I'm a small piece of that. But the important thing to think about, I think, for physicians and nurses is that their role is very, very well circumscribed and only possible with the support of often hundreds of other people.
Yeah.
Right. So how do they know whether to bring in a specialist like you or just a general orthopedic surgeon?
So I think that what they were looking at the hospital, and this is sort of in the administration level, is just the number of patients that they were having to transfer out to other facilities. And so at some point, someone did the calculus to say, hey, we are transferring far too many people out. They come here to Portneuf, they get stabilized, and no one's able to address the underlying problem. And they end up being sent to either down to Salt Lake or to Idaho Falls, or the transfer in the first place in is refused because either the paramedics know, or the trauma doctors that are deciding whether to accept a transfer in are able to know that fracture would not be able to be addressed by the team there. So I think that was the calculus behind it, was this decision of, where we've sent out this number of people, and they started that search. It sounds like they were searching for a while to find it, because apparently we're kind of rare, but but it worked out at the right time that we were looking for a job and they were looking for a person.
So that's got to be kind of exciting just on a personal level, right? That to kind of come into a new program and have some influence and be part of those decisions and working with the team to really figure out how to make it to be an excellent program.
Yes, sir. Yeah, it is. This is something that the idea of coming in and creating a program, not from scratch, because there was orthopedic call and there were surgeons performing surgery here, obviously, in the trauma team, but just sort of designing how we would respond to high energy orthopedic trauma. And we're currently in the process of implementing a hip fracture protocol, because that's one of the most common traumas is folks falling and breaking their hip. And it's something that, there's a lot of evidence coming out. Something we just recently implemented is we're doing local anesthesia blocks when patients come to the ER now. And that's something that's been shown to dramatically decrease the amount of narcotic pain medication that patients need and increase their comfort and satisfaction in the both preoperative and postoperative timeframe with hip fractures. So it's sort of stuff like that you get to implement, and you get to see the results of it with these patients that do much better with their preoperative and postoperative care. So it is satisfying. It's a lot of work, but it is satisfying.
Very cool. Very cool.
Awesome.
So you came from Florida to Idaho. That's a completely different environment to move in. You've been in July. You came in the middle of, lockdowns and isolations and all sorts of things. So shifting maybe, and not too much in the personal, but I'm just curious how that move and transition has gone in a very unusual
it was an unusual time. And, and I think all of us are sort of dealing with this. I've been singularly impressed with how quickly we were able to get a vaccine and be able to start distributing it. And I think that's something as humans that we should be highly proud of, that we've come to this point where within a year we were able to, identify a new terrible virus, identify a vaccine, and get vaccines. Now 3 candidates out there that we're able to be giving. But at the time when we moved, of course, no one was vaccinated. And so we moved across the country, we rented a camper, and we drove across the country with my then 6-month-old, and and sort of stopped. This was a very long cross country trip. I think it was 6 days. So we would drive a little bit and stop, and drive a little bit and stop, and and we stopped at military bases along the way, because I'm still in the military and the reserves, and so we would stop there to stay for the campsites, and try to be as socially distant as possible. And even now, my wife and son are still in that non-vaccinated group, and so we're still maintaining our distance. So it's been a little rough not being able to necessarily feel like we're fully integrated into the community, because it's so hard to do things. So we get a lot of takeout food, and we spend a lot of time on FaceTime and such with family, and we take hikes in the area, and we try to do what we can to be able to be in the community. But yes, it's a hard time. I think it's a very hard time for all of us. It's just something where I've personally known 2 patients that have passed away from this virus. I've lost a former professor of mine in New York, and a nurse friend of mine in New York that died from this virus. So it's been a hard year for the country and the world, I think. So I think we're starting to turn a corner, which makes me very happy. Just the idea of being able to get the vaccine myself. My mom just got her first dose of the vaccine back in Minnesota. We're getting there, but there's been a lot of loss and a lot of hard stuff for a lot of people with family members and businesses and you name it that have been affected with this. So it was an interesting move.
Yeah, I bet it was. And just, this isn't much of a question, but just maybe a comment. We go back to your previous conversation about trauma, right? And trauma can come in many different forms. And I think that this last year has been, for a lot of people, traumatic.
Yes. Oh, yeah. And that's, and even, just that, of course, the mental trauma, and that also ties into when you do have physical trauma, that it is accompanied often by mental trauma because of the changes that happen in people's lives. And so it's there is a psychological aspect to being a surgeon that deals with patients that have been injured in trauma, because a lot of time I'll spend just talking to people and kind of helping them understand. We don't always get full recovery after some of these kind of injuries, and just helping people get to the idea that this is their new normal and how they're going to adjust to that. And it's something that thankfully my time in the military has given me some really good insight into that, because you see a lot of grievously injured young folks that, you don't think about being grievously injured when you're 20 and 21. And this idea that these patients do go on and they do, make something of their lives in a way that they probably were not expecting to ever have to adjust in that manner. And so that gives me some insight, I think, to helping patients on the civilian side that are injured in ways that they also were not expecting.
Right on.
So maybe going back to your conversation about trauma, what is maybe the most miraculous recovery that you've ever seen with somebody with a traumatic injury?
Yeah, I think, there's a lot of people who've made substantial recoveries that I've seen over the years. I think that one here, which I think is an important one, is, and I'll talk about this one because she's someone from the community, and I'll try to be as general as possible so that it doesn't highlight who she is. But this was a rollover accident, a very severe injury where the patient was ejected from the car, and she had a severe pelvic fracture. In addition to that, she had both of her knees dislocated. And when your knees dislocate, that obviously destroys the ligaments that attach your femur down to your tibia, but it also can affect your blood vessels. And unfortunately, on one side of her, it affected her blood vessels. So she had a very large series of wounds to that leg, in addition to the blood vessel itself had been occluded and so there was no blood flow down to her foot. So she came initially to an outside hospital and then was immediately transferred to us when they realized that this was a severe case. She came in, and our vascular surgeon at Portneuf was able to, what we call revascularize, was able to bridge over that artery injury and get blood flow back to her foot. One of our other orthopedic surgeons was able to put what's called an external fixator on, which is pins and bars that hold the leg in place. And then we started a very long process of reconstruction. So the second day in the hospital, I fixed her pelvis. And then we proceeded, I think we did 13 or 14 surgeries to her right leg to wash everything out and get the tissues closed. And that included a lot of vacuum dressing, a very long process. The poor woman was in the hospital for about 2 months. During the course of that, another one of our orthopedic surgeons took care of the ligaments on her left knee. That's something that I don't do. And so that's kind of, can we talk about tying in where I fit in, that we have the other folks in the community that we use for doing the stuff that I don't do. It's just no one does everything. And so that's another surgeon took care of her left knee. And then going forward, that same surgeon eventually was able to do her ligaments to her right knee and has been working on her range of motion. She is walking. She has both legs. She's back to her family. And I think that's something that, she easily could have lost her leg or very well could have lost her life. And so that, that's just someone here recently that I think is, someone to highlight. There have been many others, but that would be the one that sticks in my mind most recently.
So I have a quick question. Along with the trauma that the patient is dealing with, with the injury, how have you noticed any difference in the fact that because of COVID, they can't have their family support system all visit them in the hospital?
Yes.
I know at some point they couldn't have anyone, and then it was very limited afterwards. Yes. So they couldn't have that family support.
So right now I think we're at one designated visitor, and that's only one person. They can't change that person during the course of the hospitalization, and it highlights, I think, the difficult line that all of us as a society and a world, politicians, everyone, physicians have had to try to thread this needle between helping reduce the spread of a virus that certainly has a predilection for a subgroup of people that it makes very sick and can kill, versus the normal human interactions, the keeping the businesses open, I think it's we haven't dealt with this since 1917 or 1918, where we've had these kind of this global pandemic that's affected every part of our lives. And so I've seen patients struggle with this lack of support, and to some extent myself and other folks on our team have found ourselves spending a little bit more time sometimes with these patients, just sitting down. I always try to come into a room and just sit, and, to try to make it look like I'm not trying to run out of there because I have to be somewhere else, even though I usually do. But just this idea that you want to convey some humanity to this, because this has been hard on everyone. And so I was very happy to see that the numbers are coming down dramatically in Bannock County. We're starting, the vaccinations, the whole group and the folks that have been working on vaccinations have been doing a great job. And I think we're starting to see hopefully we're starting to see we're turning the corner on this and letting people have visitors again is a big step. But yeah, it's been a rough year.
Yeah, it has. Dr. Ohalloran, we had the timer go off, but I just want to add this little piece, and it's kind of interesting from me sitting over here is, earlier we talked with Dr. Jared Bailey and Heather McGeehan with the stroke program there at Portneuf, and I'd shared on that podcast how my father had recently had a stroke, and now he's down in Arizona golfing, and just
good for him.
That wonderful process. And your comment, about 6 years ago, I was in a motorcycle accident and I had to do the whole thing. And you were saying that whole thing, the ambulance drivers, the police, the nurses, and all that piece. And fortunately for my injuries, I was able to get treated in outpatient, orthopedic surgeon, didn't have to stay in the hospital for 2 months. But I got to tell you, just from my personal experience, I am very confident, or feel very good to know that there are people like you, not just here at Portneuf, but across the country, who are working really hard to make sure guys like me can still get up and walk around. So.
Yeah, yes, sir. Absolutely.
I appreciate that.
That is what drives us, is seeing people do well. So
right. I appreciate that.
Yeah.
Well, we're excited to have you here at Portneuf, and I'm excited for the work that you're doing in the program. And one question, we'll have to have you back on, because one of the questions I was going to ask is, when do you look at the program that you're putting together and make it a success? So I think, when do you call it a success? So we don't have time to get into that, but I thought we'll have you back on the show and maybe in a year, and I'll say, okay, later, are you a success?
I think that one of my successes, I think, would be having partners. I think that's going to be, kind of bringing in some people that can help. Because I think that's,
there you go. I got someone else here.
Are suffering pretty severely. We're working pretty hard, and we're saying, hey, maybe this is time to start. So I think that's one of, when we get to the point where we can bring people on board, to have additional hands on deck, I think that will definitely be a mark of success. And then just looking at the metrics, of how patients are doing. So we'll get there. But yeah, it would be a great thing to talk about. Absolutely. Next year, unfortunately, at this time, I will be in Afghanistan. So we'll have to make that. We'll have to make that I think I can Zoom from there, depending on how our internet.
Yeah, that might be cool. Yeah. That might be cool. We can show us some cool stuff.
Yeah, we can.
Well, with that being said, we do want to remind everyone that this is also just a taste of what they'll be getting at the Emergency Medicine Conference. And so please be sure to check out our website at cetrain.isu.edu, and just in the search bar, type in Emergency Medicine Conference, and be sure to check out more information and to hear more information, just like what you've heard today. Also, if you have any questions or want to talk to us, 208-272
282.
I knew I missed it. Well, you got it?
Yes, 208-282-3372.
See, I've only done 100 of these shows. I just want you to know that. I've only done 100.
You had a good streak going there. I think in 5 episodes, you got it right.
Man, one of these days. And with that being said, too, Raylyn, thank you for being on the show today. And thank you for kind of leading the discussion on this. I really do appreciate that. Dr. Ohalloran, thank you. Thank you so much.
Thank you, guys. Thank you for having me on.
Right on.
Look forward to having you at the Emergency Medicine Conference.
Absolutely. Yeah. See you guys in May. All right.
I'll be there.
All right.
All right. Thanks.
Bye.